This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. Thank you for joining. It is my pleasure to introduce my friend and colleague, Dr. Amir Rezvan, who is the assistant professor here at Emory in cardiology. He was practicing at Grady and now is practicing at the VA. Amir graduated from Iran University of Medical Sciences in Tehran, followed by a master's in biomedical sciences and tissue engineering at Drexel University in Philly. He subsequently stayed there for internal medicine residency and then came to Emory for a cardiovascular fellowship and then stayed on, fortunately for us, as a faculty here. He's on the tenure track, focusing on the role of disturbed flow and shear stress on endothelial cells and how it interacts with the immune system. Amir has successfully obtained an R01 studying the role of a specific transcription factor in endothelial cell activation. He's received several awards, including Best Presentation at the Biomechanics Vascular Symposium, and serves as a reviewer for several journals. And I'm really looking forward to hearing what he has to tell us today about endothelial cells and COVID-19.
Thank you, Pooja, for your kind introduction. It's good to be here and talk to all colleagues here who I have the utmost respect for. My first disclosure, honestly, is that I'm not an expert in this field. And the reason I decided to talk about this is our lab looks at endothelial cell activation, and that's an area of research for us. COVID-19 certainly has some cardiovascular aspects to it. So I thought, maybe I'll be able to give a big picture of the role of endothelial cells in COVID-19. But I think there's still more things that we don't know. And the answer to most questions is maybe, maybe not, we're not sure. But I'll try my best to give an overall view of the potential roles of endothelial cells. So I don't have any relevant financial disclosures. So during the presentation, I'll briefly go over how COVID-19 affects the cardiovascular system, and then we'll try to go a little bit more into detail of how endothelial cells play into the pathophysiology of COVID-19. And then towards the end, I'll talk about some serum cytokine markers that are proposed to be used for determining prognosis of COVID-19, but that also kind of ties into the research that we're doing now, and maybe discuss that a little bit. So from very early on when COVID-19 hit, it was very quickly understood that there's a big link between cardiovascular comorbidities and the mortality associated in COVID-19 patients. So comorbidities such as hypertension, coronary artery disease, diabetes, obesity, these when present in patients always portended a poor prognosis. And on the other hand, the drugs that are used to reduce cardiovascular risk, such as ACE inhibitors and ARBs, were thought to have numerous effects that may influence the susceptibility or severity of COVID-19. So although the main presentation of COVID-19 is really in the lungs and presents with viral pneumonia and can lead to acute respiratory distress syndrome, a lot of cardiovascular manifestations were also seen in these patients. So there is evidence of some acute cardiac injury with increased troponin levels. There are reports of myocarditis with potentially direct infection by the virus. there is a predisposition to acute coronary syndrome and thromboembolism. And then some of the medications that were used in COVID-19 or were thought of being used in COVID-19 could potentially induce arrhythmias. But, one of the more important drugs that, initially came into questions were the ACE inhibitors and the ARBs, because they were thought to directly affect the viral ability to infect cells. And so we'll get back to how the endothelial cells are involved in all of this, but just to give a picture of how COVID-19 could potentially produce myocardial injury, which is known to be an association of poor prognosis. We can look at many different mechanisms. When the SARS-CoV-2 virus causes infection in the lung, due to lung injury, it can cause a supply-demand imbalance. So as the oxygen levels falls, the ability of the body to deliver enough oxygen to the tissues will be reduced. And therefore that puts the heart at risk for a type 2 MI mediated by oxygen supply and demand imbalance. On the other hand, SARS-CoV-2 can potentially directly infect the myocardial cells themselves and cause myocarditis. There's, some of these patients can be critically ill, and like any other critically ill patients, you can see stress cardiomyopathy in these patients. Importantly, infection with SARS-CoV-2 induces a lot of inflammation. And it was found that a lot of these end organ damages that we're seeing is because of the cytokine storm and significantly increased amounts of cytokines such as IL-1, IL-6, TNF-alpha, and others, which may cause inflammation-related injury in the heart. And these could also potentially lead to coronary plaque rupture and a frank type 1 MI. And at the end, an important mechanism of COVID-19 in general is thought to be microvascular thrombosis and dysfunction. So SARS-CoV-2 can affect and induce myocardial injury in multiple different ways. And one of these that we mentioned is direct infection of cardiomyocytes. So in a paper in cardiovascular research, it was shown actually that SARS-CoV-2 can infect cardiomyocytes either derived from human iPS or from human heart slices, and in some case reports from human heart biopsies, can directly bind to the ACE2 receptor on the cardiomyocyte and cause cardiomyocyte infection. And this infection was shown to be able to be inhibited by the antiviral drug remdesivir, which is the only antiviral medication right now that's been given emergency approval for the use in COVID patients. So if you look at the pathologic features of COVID-19 myocardial injury, a paper in European Heart Journal kind of showed an interesting picture showing that we essentially see a lot of diffuse macrophage infiltration in the heart. This may reflect underlying diseases rather than the COVID-19 infection itself. But you also see a number of patients showing lymphocytic myocarditis. So about 14% of patients showed lymphocytic myocarditis. 19% showed small vessel thrombi, so microthrombi essentially that were blocking the small vessels in the heart. 14% of the patients showed endocardial thrombosis, and 19% showed focal pericarditis. Again, how much of this is directly the effect of COVID-19 is not well established, but these are certainly some features that can be seen pathologically when we see myocardial injury happening in COVID-19 patients. There's a myriad of other cardiovascular events reported in COVID-19 patients. And I'm just showing a few examples here, like MI and Takotsubo syndrome, cardiac tamponade complicating myopericarditis in COVID-19 patients, some cases of SCAD, spontaneous coronary artery dissection after COVID-19 infection. And of course, the association between hypertension and hypertensive therapies associated with COVID-19 mortality. And this brings us back to the effect of the renin, angiotensin, and aldosterone system, which is important in COVID-19 infection. And initially, there was concern whether the ACE inhibitors and ARBs could be detrimental in COVID-19 patients, but a few studies showed that, in fact, patients who had hypertension and were already on RAS inhibitors, such as ACE inhibitors and ARBs, did better compared to patients who had hypertension, but whose hypertension was treated with medications other than ACE inhibitors and ARBs. And so this brings us to this central picture and role of the angiotensin converting enzyme 2 as part of the renin angiotensin aldosterone system. So angiotensin 2 is the main effector in the RAS system. And we all know that angiotensin 1 gets converted into angiotensin 2 by the role of angiotensin converting enzyme. And that's where we use the medications ACE inhibitors to prevent from this conversion and reduce the amount of angiotensin 2. But angiotensin 2 can then be converted into angiotensin 1,7 by angiotensin converting enzyme 2, which is a separate angiotensin converting enzyme, and essentially has a protective role because it's turning angiotensin 2, which is an active vasoconstrictor, an important actor in the RAS system, into angiotensin 1,7. And of course, angiotensin 2 exerts its effects through binding to angiotensin 2 receptor type 1, and that's where the ARBs, or angiotensin receptor blockers, exert their effect. So how does this play into COVID-19? It is known that the SARS-CoV-2 virus attaches to this ACE2 enzyme. And when it binds to this ACE2 enzyme, it internalizes ACE2 and therefore causes a downregulation of ACE2 expression, leading to increased availability of angiotensin 2 and its downstream effects of vasoconstriction, inflammation, and fibrosis. So initially, the thought process was that, because there was some evidence that ACE inhibitors can kind of lead to an upregulation of ACE2, that could be detrimental in providing more binding sites for the virus and kind of making the ability of the virus to infect cells more. But overall, as I mentioned, we found out that the effect of ACE inhibitors on decreasing angiotensin II is probably more important. And so overall, it was recommended that people who were on ACE inhibitors remain on ACE inhibitors. And as I mentioned, there were even some studies that suggested that blocking the renin-angiotensin-aldosterone system may actually be beneficial in COVID patients. So this is a slide that I'm going to go over in a little bit of a detail because it kind of, it's from a review article by Peter Libby and Lucia in European Heart Journal. And it kind of gives a good overview of what could potentially happen to the endothelial monolayer. So we know that the endothelium at baseline is a quiescent resting endothelium and has properties that are generally protective for cardiovascular disease. These include acting as a anticoagulant or anti-aggregation milieu, having profibrinolytic roles, importantly having anti-inflammatory roles, as we know that a quiescent, non-activated endothelium essentially resists heavy interactions with leukocytes. It has a very important barrier function, and V-cadherin and adherens junctions are important in promoting this barrier function. We all know the role of endothelial cells in vasodilators such as nitric oxide and EDGF. And of course, it could have an effect on the ROS production acting as an antioxidant as they express superoxide dismutase and other antioxidants. But when you have viral cytopathic effects, such as direct infection by the virus or encounter of PAMPs and DAMPs, such as LPS or pieces of dead cells, then endothelial cells can become activated, or cytokines such as IL-6 and IL-1 and TNF-alpha. And when endothelial cells become activated, then a lot of these protective features can flip. So they can start showing procoagulant, pro-aggregatory phenotype by expressing tissue factors, thromboxane, and CD40 ligand. They can promote neutrophils to bind and cause net formations. They can express leukocyte adhesion molecules like VCAM, ICAM, selectins, etc., which recruit leukocytes to the area. And they can also produce chemokines such as IL-1, IL-6, etc. And as these cells become activated, they also have impaired barrier function. So this activated endothelial monolayer now has reduced V-cadherin. There's some basement membrane basement membrane degradation by the matrix metalloproteinase. There's some endothelial sloughing and death that then exposes the basement membrane to the leukocytes and platelets and can therefore be more procoagulatory. And then you have a vasoconstrictor phenotype. So they can produce thromboxane and have a decreased nitric oxide production and also be pro-oxidant. And all these changes in the phenotype that the activated endothelial monolayer has can then lead to end organ damages. And so in small vessels like those in the alveoli of the lung, this can lead to capillary leak and microthrombi, leading to ARDS. It can predispose plaque rupture and thrombosis in coronary arteries. And this prothrombotic environment can lead to thromboembolic ischemic stroke. The microvascular injuries and vasoconstriction can lead to acute kidney injury, and deep venous thrombosis can occur because endothelial dysfunction is an important part of the virtuous triad and sets the stage for pulmonary embolism, essentially. And so endothelial cell switching from a quiescent monolayer to an activated monolayer can essentially be very important in a myriad of different functional effects that we see in COVID-19 patients. So again, in the absence of disease or stressors, platelets and endothelial cells don't directly interact a lot, but when you have comorbid or comorbid conditions that increase the risk of CVD, like diabetes, obesity, and aging, you have an activated environment and increased inflammation. And when you get this SARS-CoV-2 infection, this may cause direct endothelial damage and dysfunction, lead to thrombus and emboli formation, and therefore, a combination of therapies targeting thrombocytopathy as well as endotheliopathy, inflammation, and coagulopathy are needed probably to reduce morbidity and mortality in patients with COVID-19. So essentially, the take-home message from this slide is that SARS-CoV-2, although can directly, potentially affect endothelial cells, it's probably more importantly affecting endothelial cells indirectly by creating this inflammatory milieu that leads to endothelial cell activation and a prothrombotic phenotype. So I'm going to mention a few studies that essentially bring into focus how this endotheliopathy can be associated with COVID-19. So the first study is a study that used a single center cross-sectional method looking at patients who were in the ICU, COVID patients who were in the ICU, and using asymptomatic non-hospitalized controls. And essentially they looked at markers of endothelial cell and platelet activation, including von Willebrand factors, soluble thrombomodulin, soluble p-selectin, and soluble CD40 ligand, as well as a series of coagulation factors, anticoagulants, and fibrinolytic enzymes. And their final result was that, the mortality in these patients was significantly correlated with the amount of von Willebrand factor and soluble thrombomodulin. And essentially they used this correlation to assert that this endotheliopathy, as they call it, is present in COVID-19 patients, and the degree of this pathology seen in endothelial cells is associated with critical illness and death. And so maybe if we find ways to identify this endotheliopathy early on, we may be able to find strategies to mitigate the progression and improve the outcomes of these patients. So in a paper in Lancet very early in 2020, Varga et al. Presented a case series of 3 patients in which they did post-mortem analysis showing the presence of viral elements in the endothelial cells themselves. But mostly the accumulation of inflammatory cells with evidence of endothelial and inflammatory cell death. And so these findings overall suggested that the SARS-CoV-2 infection may facilitate the induction of an inflamed endothelial cell or endothelitis in different organs, such as the lung, kidney, and the heart, potentially through a direct consequence of viral involvement, but most importantly, the effect of host inflammatory response, and that the induction of apoptosis and pyroptosis may have an important role in the endothelial cell injury seen in patients with COVID-19. Another study showed that if you take the plasma from critically ill patients and use it on cultured human pulmonary microvascular endothelial cells and use cell cytotoxicity as a readout, you can show that this pathology seen in endothelial cells and endothelial cell damage can be induced by the plasma from these critically ill patients. And that, this endotheliopathy could be an essential part of the pathologic response of severe COVID-19, which leads to respiratory failure, multi-organ dysfunction, and thrombosis. And so it's the cytokine storm that we're seeing in these critically ill patients can affect endothelial cells directly. And whether this, is only important in the lung, as they showed with the human pulmonary microvascular cells, or in the vasculature overall, is a question that needs to be addressed, really. So because of this importance that was felt that endothelial cell dysfunction has in COVID-19, the European Society of Cardiology working group for atherosclerosis and vascular biology and the Council for Basic Cardiovascular Science essentially put out a position paper saying that, there's enough evidence linking endothelial cells to SARS-CoV-2 infection. These include the expression and function of the receptor ACE2 in the vasculature, the prevalence of a Kawasaki disease-like syndrome or a type of vasculitis in COVID-19 patients, especially in children, and evidence of endothelial cell infection with SARS-CoV-2 in patients with very severe and fatal COVID-19. So they essentially went over the potential dysregulation that's caused in the endothelium, and I found these two pictures again helpful to re-emphasize that the healthy endothelium is quiescent, it has intact junctions, has a anticoagulant phenotype with no platelet adhesion and an anti-inflammatory phenotype, which helps vasodilation. But when you have a cell that's infected with SARS-CoV-2, as you can see in the cell in the middle cell here, as SARS-CoV-2 binds to the ACE2 receptor and can potentially infect the endothelial cell, this itself can be a potential mechanism for reducing the ACE2-mediated regulation of vascular tone that we see. So essentially increasing the levels of angiotensin II. And on the other hand, by producing cytokine storm, as you can see in the cell to the right, lead to an activated endothelial cell where now you have lost your good cell junctions, and the endothelial cell layer is more amenable to the passage of the immune cells. There's more platelet aggregation and a more pro-inflammatory phenotype. As a result, there's also vasoconstriction and some apoptosis seen in the endothelial cells. So how can we intervene to reduce endothelial cell activation? So in this picture, endothelial cell infection with SARS-CoV-2 is shown to cause dysregulation of RAS, apoptosis, thrombosis, and inflammation, shown by the red tones here, essentially. And the proposed interventions are shown in green. So modulators of RAS, such as ACE inhibitors, ARBs, and potentially recombinant ACE2, could prevent increased angiotensin II and essentially prevent the activation of the RAS system. The statins can potentially have an effect in this endothelitis by having an inhibitory role on apoptosis and ROS production. On the other hand, as far as the thrombotic microenvironment goes, platelet inhibition and anticoagulants could potentially be useful in decreasing the thromboembolic phenomena that are seen in COVID-19. And cytokine inhibitors, statins, and the dexamethasone and other anti-inflammatory agents could reduce the inflammatory milieu that increases this endothelial cell activation and the potential downstream dysfunction that we spoke about. And of course, a healthy lifestyle against endothelial dysfunction can also be helpful. So potentially quitting smoking or addressing obesity, type 2 diabetes, and hypertension can also potentially be important in reducing endothelial dysfunction in patients with COVID-19. So they had a few statements regarding the research that needs to be done on the role of endothelial cells and COVID-19. And essentially, their suggestions was that endothelial biomarkers and tests of function, such as flow-mediated dilation and arterial stiffness, should be monitored in studies of COVID-19 outcome and treatment effects. And the having high-quality data will be important to enable the stratification of COVID-19 patients who have the potential highest prothrombotic and cardiovascular risk and allow some tailored treatments. In addition, because of the significance of SARS-CoV-2 mediated endocytosis and downregulation of ACE2, as the significance of this on cardiovascular health is not very certain, but the data from ongoing clinical trials to test recombinant ACE inhibitor, to test the recombinant ACE2 enzyme may be important in addressing whether or not this endocytosis and downregulation of ACE2 is actually having an important mechanistic role. and that the effects of SARS-CoV-2 on endothelial cell function, including things like endothelial activation, leukocyte recruitment, platelet activation, etc., should be studied in both endothelial cells from microvascular and macrovasculature. And aging should also be paid attention to as an important determinant of influencing cellular senescence and oxidative stress, which may be important in COVID-19 outcomes. The effect of common cardiovascular medications such as the statins and beta blockers on the endothelial cell response to SARS-CoV-2 should also be explored, including their influence on ACE2 expression and viral infectivity. And the long-term cardiovascular effects following recovery from COVID-19 must also be looked at as a planned follow-up in COVID-19 patients. There were some more recent insights into the role of endothelial cells in COVID-19. We spoke about some evidence of endothelial cells being directly infected by SARS-CoV-2, but a recent study published in Circulation last month kind of brought that under question. They showed that, you know, when they cultured endothelial cells in the expression of ACE2 in endothelial cells was very low, and although there was some presence of the viral particles in the cells, they weren't really undergoing a replicative infection. And so whether or not this direct infection of the endothelial cells by SARS-CoV-2 is happening or not, and to what extent it's important, is really under question. There was another study last week that showed some interesting results confirming a previous study that was published in Cell Metabolism that kind of showed that there's a lower mortality seen in patients with COVID-19 who are taking statins. And this kind of brings back the question whether statins can kind of have this immune modulating effect and the direct effect of endothelial cells and reducing the inflammatory phenotypes of endothelial cells apart from their roles on LDL cholesterol. So I'm briefly going to go over some evidence of some cytokines that can be used as markers of COVID-19 severity. And so a interesting study came out in Nature Medicine that looked at identifying immunological traits common to individuals in a high heterogeneous cohort of 63 patients with COVID-19 who were treated in London, and included 55 controls to compare, including patients who were previously COVID-19 seropositive and individuals who were hospitalized for non-COVID-19 lower respiratory tract infections. And the results essentially showed ongoing dynamic immune responses could be clearly segregated based on multivariable analyses and component analysis that could separate patients from the controls, including those who were recently recovered seropositive patients. But very importantly, they found a set of traits that included a triad of 3 different cytokines, IP10, IL-10, and IL-6, which could effectively anticipate the subsequent clinical progression of these patients. And there are other papers that essentially look at a number of cytokines, such as IP10, IL-10, and IL-6, as markers of COVID-19 severity. So another paper that was published looked at plasma IP10, looked essentially at 48 different cytokines in the plasma samples from COVID-19 patients, again, comparing the levels in critically ill, severe, and moderate patients with healthy controls. But there are a number of different cytokines that can be significantly elevated in COVID-19 patients. But again, one of the cytokines that comes up in many of these markers of COVID-19 severity is IP10. And again, in this study, the combination of IP10 and MCP3 had the biggest improvement in the AUC curve to predict progression of COVID-19. IP10 and MCP1 were also again shown as biomarkers associated with the disease severity of COVID-19, and a longitudinal immune profiling revealed a signature of myeloid components associated with COVID-19 that again found, apart from shifts of neutrophil to T cell ratios, that elevated serum levels of IL-6, MCP1, and IP10 were really important as part of this myeloid signature that was associated with COVID-19. Now, other cytokines and growth factors and growth differentiation factors have also been shown to be able to predict COVID-19 severity, or at least show association with severity of COVID-19. But the reason that I kind of brought up IP10, or you know, one could see that that IP10 had kind of a recurrent presence in many of these studies that looked at cytokines in COVID-19 patients as markers of severity or as predictors of progression. So while inhibitors of IL-1 and IL-6 are being studied currently as potential treatments in COVID-19, and you know, IL-1 and IL-6 are very well established immune activators, IP10 is kind of less known. And essentially interferon gamma-induced protein 10 is also known as CXCL10, is a very small cytokine, less than 10 kilodaltons, that's secreted by monocytes, fibroblasts, and endothelial cells in response to interferon gamma. And what it does is that it binds to the CXCR3 receptor and acts as a chemoattractant for monocytes and macrophages, T cells, natural killer cells, and dendritic cells. But it also promotes T cell adhesion to endothelial cells. And it's shown that endothelial cells can express IP10 when they're activated, and that angiotensin II increases the expression of IP10 in endothelial cells and mediates apoptosis and senescence in endothelial cells. It's also being shown to be induced in endothelial cells by interferon beta and VEGF. So we can see that there's a lot of components that is, there are a lot of activators of endothelial cell expression of IP10 that are up in the COVID-19 patients. So it's reasonable to ask if part of this IP10 that is seen in the serum of these COVID-19 patients and could potentially be a marker or even a predictor of the progression of COVID-19. Could part of this be produced by the endothelial cells and not just the immune cells. So interestingly, while again, IL-1 and IL-6 inhibitors are in clinical trials, there's no current trials looking at neutralizing IP-10, but in a study back in 2017, before COVID-19 era, it was shown that IP-10 neutralization can actually ameliorate LPS-induced ARDS in an animal model. And so essentially in our lab, we're kind of interested in looking at the role of endothelial cells and their production of IP-10 and whether or not the regulation of IP-10 in endothelial cells could potentially have a mechanistic role in COVID-19. And so, you know, it would be, I would be open to hear from any of our colleagues who are doing any studies looking at the clinical aspects of endothelial function in COVID-19 patients to see if we can potentially take a look at the role of IP-10 in this process. So in summary, I think it's fair to say that COVID-19 clearly has a significant cardiovascular component to it. Although some have called COVID-19 essentially an endothelial cell disease, I think these are our colleagues who are somewhat biased towards the role of the cardiovascular system, but I think it's fair and really no question to say that endothelial cells do play an important role in the pathophysiology of COVID-19 via their effects on coagulation, inflammation, barrier function, and ROS production. And serum cytokine markers such as IP-10, IL-10, and IL-6 could be used for determining the prognosis of COVID-19, although certainly more studies are needed to confirm this. But also these markers could potentially provide some insights into the pathophysiology of COVID-19 and whether or not endothelial cells could be contributing to the serum levels of some of these cytokines mentioned above really needs to be part of ongoing studies. So thank you for your attention. I'm open to some questions and discussion.
Thank you, Dr. Rezvan, for that very nice review. We learned a lot. I'll take questions, and while people are typing in their questions in the chat, maybe I'll start off with one. Can you highlight for us sex differences in this particular, you know, that's been observed. So what is known about the ACE2 and, you know, is there a true sex difference or what are your thoughts about that?
You know, it's a very good question. And, you know, it's, I think the overall thought process is that, you know, COVID-19 has been more severe in males compared to females, potentially, if that's what you're getting at. And, you know, I'm not sure personally in differences of ACE2 in male versus female. I haven't looked into it. I don't know if there is any specific difference or not. But I think you bring up an important point, and that is, you know, when doing these in vitro studies, for example, using endothelial cells to look and see how these cytokines affect endothelial cells, or if the virus is binding to endothelial cells via ACE2 or not, it is important to use cells from both genders. You know, a lot of times these studies are done one specific endothelial cell type and really not paying attention to the potential gender differences. So I think that brings up an important point when doing in vitro research, that there may be such differences present.
Yeah, there does seem to be a paradox though, right? Because, a lot of the autoimmune inflammatory consequences tend to affect women. So, all these autoinflammatory disorders are associated with adverse risk in women. But then this particular virus that induces such a terrible inflammatory sort of cytokine response, women seem to do better compared to men. So,
no, that's a very interesting point that you bring up. And you're right, it is known that most autoimmune diseases, for example, are more prevalent in women. But like you said, women seem to be doing better with COVID-19. And whether or not that can be related to ACE2 specifically and the infective properties of SARS-CoV-2 on endothelial cells, or just the different inflammatory milieu that we see in the male and female patients, I don't know. It's really something that should be looked at.
yeah. Dr. Taylor has a comment in the chat box. We had a blue sky meeting looking at vascular aspects of COVID-19. So if you were not able to join that, please email Dr. Taylor to let him know, because we're going to be starting a working group just specifically for people who are interested in investigating or participating in this area. Any other questions or thoughts from the audience?
So I'd be happy to hear comments, but again, I understand that this is, fortunately, I think when comparing how things are going now to the initial identification of COVID-2 and the initial phase of the COVID-2 era, I think clinically, at least the patients are doing a lot better now, as our clinicians have really found better ways to treat these patients, at least in a supportive manner. But the overall picture of the mechanistic processes, I think, is still pretty muddy and needs a lot of research to be done.
Mm-hmm.
I can ask one if it's
yes, absolutely.
I'm aware of a study of colchicine in this regard, and as you know, colchicine was shown to have an effect in cardiovascular disease and anti-inflammatory effect. I know it hits IL-6, but I don't know anything about how this study has gone. Tardif in Canada is doing this study. The same guy that did the cardiovascular study. But is IP10, do you know anything about colchicine and IP10?
I don't know any direct relationships whether colchicine affects IP10 or not, but it's certainly a good question to look. I mean, colchicine has this overall anti-inflammatory effect, but again, whether or not it directly affects IP10, I don't know. I haven't come across any studies to specifically that specifically looked at it, but it's a very important and good question. Thank you, and I think it's worth looking into. Thanks.
Dr. Taylor has a question. What is known about long haulers in terms of vascular dysfunction?
I think that was part of the position statement that the European group had put out, and that is that we really need to look into what happens into patients who either recover from COVID-19 or those who have long-term effects of COVID-19. Pooja, I don't know if you know any effect of endothelial dysfunction in the clinical settings. I don't know of specifics, specific roles, a specific phenotype in the long haulers. But
Yeah.
I would assume that there's some level of vascular dysfunction. Are you aware of any studies such as the clinical measurements of endothelial dysfunction?
Yeah, I am not. And the RO1 that we just put in on Friday with Jonathan and I, we specifically kind of asked, this question of what happens after a person has recovered and looking at vascular function. But, one of the things with long haulers, I think the hard part is going to be, how many of these people already had endothelial dysfunction before, because that's the part that we won't have, The other thing that you bring up, Amir, your nice slides with like inactivated endothelial function. So when it's quiescent versus, I never think of anything that's biologic as sort of quiescent. I know we like to think of it like that, but we're living, breathing human beings. And so this idea to me that endothelium is nice and quiet it's not baseline. I mean, I feel like it's getting hit all the time with different, so what are your thoughts about that?
So that's a great point. And I think, quiescent kind of may give that passive or silent role, yeah. That's not at all what we mean when we say a quiescent endothelium. So, when we say quiescent endothelium, essentially we mean a healthy functioning endothelium, and that is an endothelium that, may take all these hits, but not take on a pathologic phenotype to itself, and so, by saying that they're quiescent, we mean that they're not actively proliferating, they're not actively migrating a lot, that's the idea.
Yeah. Okay, any other questions or comments from the audience? If not, it is 8:30, so perhaps we'll go ahead and close. Thank you so much again, Amir. That was fantastic. Gave us a lot to think about.
Thank you, everyone, for bearing with me in this talk of somewhat confusing nature, I think. But I think it's good to see that other people are working on this, and I certainly look forward to talking with you and others who have already been looking into this. Thank you.
The preceding program is copyrighted by Emory University.